Good evening, everyone, and welcome to tonight's CPD webinar, Responding to Child Sexual Abuse in Primary Care. My name is Janina Beckman. I'm one of the domestic violence educators at Central and Eastern Sydney PHN. Before we begin, I would like to acknowledge the traditional custodians and sovereign people of the lands across which we work, and I recognize their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. And I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. For housekeeping, please submit any questions you might have into the Q&A function at the bottom of your screen. We may have time for questions at the end after our panel discussions. We do not have the chat function enabled during this session, but we have, as I just said, the Q&A function enabled down below. At the end of the webinar, an evaluation survey will pop up on your screens, and a post-training survey will also be emailed to you. And a reminder that this event is approved by the RACGP CPD program for 1.5 hours of education activity. So there's also quite a few events coming up. And if you are registered in any, please hop onto our assessment site and register for what interests you. Now, before I hand you over to the people who will be presenting to you tonight, I'd like to introduce them. So tonight we have with us Dr. Jennifer Martinez, Malika Rees, and Robin Norton-Smith. Jennifer is a staff specialist at the Sexual Assault Service at the Royal Prince Alfred Hospital in Camperdown in Sydney, which is the state's busiest department. And when she's not overseeing the placement program there to train out-of-area forensic nurses or teaching at the New South Wales Health Education Centre Against Violence, she's putting her skills to good use as a GP at Headspace. Jennifer unwinds by immersing herself in a horror movie or a book. At home, she is a ringleader of a lively household that includes her husband, 4 teenagers, and a rescue pit bull, who she says may be the most relaxed member of the family. We also have with us tonight Malika Rees. Malika is an MC, a teacher, a speaker, a writer, a musician, a producer, and a storyteller, so she wears many hats. Malika has been performing for over 20 years. She has performed at many places, including TEDx, Woodford Folk Festival, Sydney Opera House, and Edinburgh Fringe. She's a founding member of the Church of the Clitori and soon to publish a book about death for little ones. In 2010, she successfully had her abuser convicted and the name suppression order dropped. So as an advocate about child sexual abuse, she works with women's groups, speaks against domestic and family violence, and is Wollongong Citizen of the Year 2025. Malika connects communities, making a positive difference in people's lives through laughter and song. Experience working in government and non-government roles in Canberra, Sydney, Perth, and London, with a focus on well-being and women of children and their experiences of violence, abuse, and neglect, including domestic violence and sexual assault. Robin is focused on survivor-led, patient-centered care. She has worked with families pre- and post-child protection services involvement, including a statutory role in child protection. With extensive experience in the New South Wales service system, Robin provides support to primary care providers to ensure patients receive all that is available as the sexual violence and child sexual abuse navigator for CESPIN. And with that, I hand you over to Dr. Martinez.
Thank you, Nina, for the very warm welcome. And thank you everyone online who has taken the time out this evening to be here tonight. And just to acknowledge that discussing child sexual abuse can be challenging and confronting. So if at any point you need to take some time out, please do. Your well-being matters, and it is important to look after yourself through the session. I also want to just quickly acknowledge the PHN for preparing the presentation, which I'll be speaking to today. Now, these numbers for self-care we will put up at the end of the webinar for you to refer back to if needed. So I guess in terms of what we will hopefully be able to get you to do today, it will be to recognise and respond to disclosed or suspected child sexual abuse, which I will refer to as child SA or SA throughout the webinar, and do that in a person-centred and trauma-informed way. We also hope that you'll be able to better understand local referral pathways to link current and historical survivors of child SA for specialised supports, as well as, hopefully contribute to, well, I guess ultimately contribute to improved short and long-term health outcomes for victim survivors of child SA. So, in summary, the purpose of today's session is to help you feel more confident, more equipped when responding to cases of child SA. And my hope is, or our hope is, that you leave today with increased knowledge, with practical skills, and a stronger sense of support for both your patients and yourselves as professionals. So, in terms of content, we'll go through a few definitions and stats, what we some facts in terms of improving our understanding of victim survivors and perpetrators. We'll touch on consent law and mandatory reporting, but the real meat of the session will be around the primary care response, which is essentially recognizing the signs, responding with empathy, and referring for support. Um, and so, I guess, as engaged advocates, I really encourage you to consider how these approaches can be shared with others in your practice, whether that be your immediate peers, your practice manager, your admin staff, your nurses, physios, or if you're in a teaching role, your registrars or students, and really broaden the impact beyond today's session. So, as we think more broadly about creating safety, I really encourage you to reflect on how welcoming and approachable your practice feels, not just for adults, but also for children and young people. So, remember, a sense of safety starts the moment a patient walks through the door. And you really want to consider whether your environment, your practice environment, is truly person centered. So, by person centered, we mean, do you have, flexible seating that accommodates a range of body sizes? Is the signage simple and easy to understand? Is staff trained to greet patients warmly and empathetically, so person-centered? But also, like, from a trauma-informed perspective, does your practice have a private space where patients can talk confidentially with reception? Do your posters and resources reflect inclusivity and diversity of your community? So, like, small changes in your practice environment can make a meaningful difference in helping patients feel safe and respected and really ready to engage with the care you have to offer. So, to respond effectively to child sexual abuse, it's important that we define what that is. And it basically involves acts that expose a child or a young person to sexual activities they do not understand, they cannot consent to, or unable to consent to due to their age or development. These acts are not accepted by the community, or they are unlawful, or they are both not accepted and unlawful. And this includes sexual activity, which is physical or non-physical, and it's activity that exploits a child's vulnerability. Um, so it includes contact behaviors, so physical touching, non-contact behaviors such as sexting or exposure to pornography, obviously prostitution, or circumstances where they are at risk of being sexually exploited, and underage marriage or similar religious ceremonies. And it's essential to also clearly understand the concept of consent when we're discussing anything about sexual abuse. So, consent must be given freely. It must be given by someone with full capacity and communicated clearly, so either verbally or through actions. And under New South Wales law, the age of consent is 16, meaning anyone younger is legally incapable of consenting to sexual activity, even if they say yes. There are a few exceptions to this. So, for example, if both people are willing and close in age, a 14-year-old may consent to sexual activity with someone who's no more than 2 years older. And then at the other end of the spectrum, just keeping in mind the legal age of consent is 16. So, other end of the spectrum, if a young person is under the special care of another person, such as a teacher or a coach, a religious leader, or a carer, that legal age of consent increases to 18. And this protects against abuse of power and it recognizes the increased risk in these relationships. So you can see that it is important we speak about sexual violence and child SA because it is so common. So in Australia, there were over 36,000 reports of sexual assault. That was in 2023. And of these victims, about 85% were women and 41% were young people aged between 10 and 17. So that really highlights how many young people are impacted. And as you can see in this infographic, that almost 30% of people living in Australia, so 30% of people living in Australia have experienced child sexual abuse. And within that proportion of people, um, an overwhelming amount have experienced more than one event, and 40% have experienced more than 6 events, which is terrible. And it's important to recognize that sexual violence is rooted in power imbalances. And while women and girls are disproportionately affected, anyone can be a victim, and that includes men and boys. Um, but vulnerability goes beyond gender alone. So certain groups face even greater risk, and that includes people with disabilities, those living in aged care or institutional settings, culturally and linguistically diverse communities, and individuals who have experienced violence in the past. So these vulnerabilities aren't accidental. They stem from systemic factors like discrimination, from not being believed, from their social isolation, from dependence on others for care. And research, it shows that people with disabilities are twice as likely to be affected by sexual violence. And the numbers are even more alarming in specific settings. So, there was a royal commission into aged care that found that 50 women are sexually assaulted every week in residential care across Australia. And among women who have intellectual or mental disabilities, up to half will experience sexual violence in their lifetime. So these statistics really highlight the urgent need to understand and address the power dynamics and barriers that put some community members, our patients, at greater risk. And I guess ultimately recognizing this context isn't just about awareness, it's about ensuring that we are alert to early warning signs, the red flags, and being better equipped to support those most impacted by sexual violence. So, further to this, the insights of survivors, such as our lived experience expert, Malika, inform how we can better support people in disclosing experiences of child sexual abuse. So, this segment is presented by Shona, who is a survivor and advocate, and she discusses disclosure from a survivor's point of view.
My name is Shona, and I'm a victim survivor of family and domestic violence and child sexual abuse. I'm also a mum. I have a 5-year-old daughter. I also participate in various advocacy projects. I think it's important for people to have conversations about child sexual abuse because although it's uncomfortable, I think it's necessary to incite any kind of change. I wish that I had a lot more support than I did. I certainly felt like I was flying blind most of the time. My household that I grew up in was definitely a culture around secrecy. And one of the main things I learned very early on was not to discuss what was happening at home with anyone outside of the family. And then on top of that, I felt like I didn't really receive very much education at school, if any. I think there are a number of ways to create a safe space for children. First of all, is definitely starting as young as you can and teaching them things in age-appropriate ways. So for example, bodily autonomy, asking, if the child consents to kisses and hugs and things like that. And also just active listening, not talking at them, being open to discourse, open to listening to questions and not shaming them, when they ask something that you might be embarrassed about. We don't want to be projecting our own feelings onto that conversation. I think it's extremely important for adults to be having these conversations with other adults because we need to be normalizing these conversations and getting comfortable with the uncomfortable. If we're not talking about it, then it's just going to continue to breed in silence.
So, I guess one of the most important ways we can support victim survivors is by understanding how abuse is disclosed, especially by children and young people. So, firstly, children rarely lie about sexual abuse. And the research does tell us that less than 5% of all sexual assault allegations are false. And most of those stem from quite complex reasons rather than from malice. And, instead of disclosing clearly, children often reveal abuse in indirect ways. So, with things like very vague comments, behavioral changes is usually the most obvious way, or emotionally withdrawing from family or socially. And these are signs that are often missed or misunderstood. Another reason is so fear of retribution is common, especially if the perpetrator is someone close. So children usually worry they won't be believed, or they might want to protect other people, like their siblings, or even the person harming them. And when a disclosure is retracted, usually it's a reaction to pressure or guilt or fear, and it's not a sign that the initial claim was false. Um, So I guess in terms of vulnerability and long-term impacts, the shame, the self-blame, the fear, the stigma, um, that all plays a very huge role in why victim survivors don't come forward. And these feelings are extremely common and often really deeply internalized, especially when the abuse is perpetrated by someone they know and trust. And just remember that, intimate partners are usually the most common perpetrators of sexual violence. So, other reasons for non or delayed disclosure are confusion, um, or a failure to recognize the experience as abuse, um, due to rape myths. And I actually see this all the time as a sexual assault forensic medical examiner. A lot of the patients that do finally present with a support person. They are clearly telling me a history of something that has happened that is clearly sexual assault, but they still do not believe or understand that it is sexual assault. Um, Another thing to keep in mind is that perpetrators often deliberately target vulnerable children and young people, as well as adults, and they use that power, they use fear and grooming tactics to control them over time. And, victim survivors, um, they experience ongoing impacts. So many show up again and again in the healthcare system, especially in our general practices, and in our mental health settings, and without always disclosing the underlying issue. So, in summary, I think we need to recognize that sexual violence affects people of all ages, um, including older women who are reporting higher rates of abuse, and just normalizing conversations across age and gender and background is really essential. And, by challenging myths and improving our understanding, we can create these safer spaces and more effective responses for survivors of sexual violence and child sexual abuse. In terms of understanding perpetrators of sexual violence, which we'll just touch upon, like we said, the majority of sexual abuse is committed by someone the victim knows, and it is commonly a relative, a friend, or a neighbor, or a partner, or a housemate. And by virtue of this, it may very well be a patient of the practice. So keep in mind that abuse by strangers is much, much, much less common. And while, 90% of perpetrators are male, there's no single typical profile. Perpetrators come from all backgrounds, all ages, and communities. And interestingly, boys and men aged 15 to 19 represent the highest proportion of known perpetrators. And that really raises important questions about early intervention and social messages that are received by young men. Perpetrators also often create like a special or an exclusive relationship with their victim. And that is done in order to build trust, to manipulate and isolate, and prevent disclosure from occurring. And they tend to be really strategic in targeting vulnerability, as mentioned before. So they choose victims perceived as less likely to be believed or who have heightened dependence, such as children and young people or those living with disabilities. And, regarding tactics and the patterns of abuse, sexual abuse, the actual sexual abuse that happens, it rarely happens all at once. So it often builds gradually. And as the boundaries are slowly um, and repeatedly crossed over time, the victim can become desensitized, and it makes it harder to recognize or resist what's happening. And perpetrators usually use a mix of different tactics. So that's the intimidation, that is the emotional abuse, the fear, manipulation, social isolation. And it creates that environment where the victim feels overwhelmingly powerless. And, their goal is power and control. It's usually not about sexual gratification. So that power control, it leads to self-doubt for the victim, and a lot of the times disbelief from those around them. And in terms of the actual abuse, that takes many forms. So it might involve pressuring someone into unwanted sexual activity or unwanted intimacy, through to coercion or tricking someone into sexual acts, non-consensual recording or sharing of really intimate images, all the way through to overt, sexual assault and rape in terms of sexual penetration. The other thing, just to note, is a recent study on self-reported experiences. It found that 1 in 5, so 1 in 5 Australians have admitted to some type of perpetration. And it's an unsettling reminder that sexual violence, it's not rare, and it's not happening elsewhere. It is very, very common. So I guess with this section, this is in regards to the primary care response, and this is the important bit where you come in and you can really make a difference in the trajectory of someone's life. So we want you to be able to feel comfortable in recognizing and knowing the signs, and how to respond to a suspected or disclosed child sexual assault. We really want the response to be person-centered, so with that respect and empathy, and trauma-informed, so adding in that safety and that choice and empowerment. And where there is consent to, make those appropriate referrals. Now, your response will differ depending on whether your patient is a child or a young person disclosing recent sexual assault, or an adult disclosing historical child sexual assault. But the principles are pretty much the same. So in terms of recognizing, so the first step, recognizing the signs, children and young people who have experienced sexual violence, we know that they access health services more frequently, and those experiences can lead to a range of very poor and physical health outcomes. And those effects can really be either immediate or persist over the long term. So we need to recognize in order to respond in a timely manner. So there are 3 groups of the red flags that you can look for in order to recognize the signs of possible trauma, and from that possible child sexual abuse that has happened. So, whether or not that child or a young person is especially vulnerable. So they are children who are isolated, who are in out-of-home care, who are living with a disability, children who you have concerns about their carers, or have had a past history of abuse, if you know they've been exposed to domestic and family violence, or if they are children or young people who have already had interactions within the justice system. So are they vulnerable people? The big thing with children and young people is that externalization. So has there been a recent change in behavior? And a lot of us know that that's how we recognize something is wrong with the person. And I guess specifically for possible child sexual abuse, it may withdraw from family or social life, disordered sleep or eating, substance use and self-harming, risky behaviors, school refusal, and importantly, like very concerning sexual behavior or an inappropriate sexual talk. And the last kind of group of red flags to consider are there new physical symptoms? So that new bedwetting, do they have recurrent UTIs? STIs is a big red flag, very obvious. Genital pain, skin changes, especially in the genital region, and just undifferentiated recurrent symptoms as well. So just speaking more to the behavioral changes in terms of sexual behavior, it's important to recognize what is normative, problematic, and harmful. So in terms of normative sexualized behavior, that's behavior that is developmentally appropriate. So for example, if a 5-year-old, was playing doctor from time to time with another child of a similar age, where both children are curious about differences in bodies, we would consider that kind of play as mutual. It's non-coercive, and it stops when there is redirection by an adult. And if that is something that you pick up on, that is when you provide opportunity to talk and explain and provide that support. Then moving up in terms of concerning sexual behavior is something called problematic sexualized behavior. So that's when it is not developmentally appropriate. So an example of this would be if you had an 8-year-old that was repeatedly touching their own genitals in public or at school, despite being told not to. So this behavior isn't age typical, it is disruptive, and it's continuing even after adults have set clear boundaries and have intervened. So, it might indicate that there's an underlying distress for that child, that they may have been exposed to explicit material or they have some kind of unmet need. And so something like this, it's a red flag. You need to monitor and provide support. And then further up the spectrum is harmful sexualized behavior. And that is definitely not developmentally appropriate. And so, for example, if that was a 12-year-old who was forcing a younger child to watch pornography or participate in sexual acts, uses threats, or refuses to stop when the child resists, these are acts that involves coercion. It's there's a significant age difference or power difference, I should say. It's secretive, it's aggressive. So this strongly suggests that there is trauma here, there's abuse, and this person is at risk to others, and that would need immediate attention. So the behaviours just need to be looked at in terms of age and development. And when you do, get some kind of disclosure from either a victim or a perpetrator who is a child or young person, you need to approach that with sensitivity, you need to avoid shaming, and you need to focus on support and safety for that child and young person. So this next segment is a little snippet on what we can do to make things difficult for people to disclose child sexual abuse, and things that we can do that makes it easier for people to disclose child sexual abuse. I'm just trying to move on to the next slide, but I don't know how many of you online have identified with the practitioner in the first half of that segment. And identified with the practitioner in the second half of the segment, but I certainly have been in both positions. And I do remember the regret when I didn't actually just make that leap and ask the question. And it is a very, very difficult thing to do, to recognize, you know what, I think something's happened, but how do I actually respond? And if you've never asked before, it's not a natural thing, and you really do second guess yourself. But it is good to have scripted responses, which may seem very unnatural to yourself, but to the young person or the child or the adult on the other side, on the receiving end, it does make a world of difference. Just the fact that you have acknowledged something has happened and you are curious about it. So a lot of these things here are very doable, and they, like I said, they may seem unnatural saying it, but they do work. So something that I like on this screen is centering it around what my role is. So that first speech bubble of my job is to keep kids safe. You know, some kids worry about their bodies. Do you? And therefore, you've kind of normalized the question. It sounds like something that you do ask everybody. Has anything happened to you that has made you feel hurt and unsafe? And then if you're comfortable about it and the conversation permits you to ask something more specific, you can just say, has anyone ever touched or hurt your private parts? And then if you had a parent, you can ask them if they've noticed any patterns in certain triggers, or if you've noticed certain people has triggered worrying behavior in their child. And if that child or that young person has felt that it was the right time for them to disclose that sexual assault has occurred, that is when you immediately validate. And so these 5 things on the screen are things that I say several times a week to patients. And, you know, just immediately saying, I'm really sorry this happened to you. It is not your fault. That it's not your fault. Those 4 words are extremely, extremely powerful. And like I said, I don't know the experience of practitioners online, but I see this all the time. I see the patient's immediate relief at just saying it's not their fault, because the whole time they've been holding on to this experience, they've told themselves it is their fault. It is their fault this happened to them. So very, very powerful words. If you're going to say, one thing, it's not your fault, it would be my pick. Telling them that you believe them is powerful. Thanking them that you told them. And then following that up with, I will help you. And you will know, you may not know specifically how to help them, but you will know which pathways to take or who to call for help at the end of this webinar. So just touching on mandatory reporting, this is a topic that some people get very funny about, but it's something that you know, if you're very hesitant to use, you know, once you take the leap and you do it, it is a bit time consuming and a bit painful to do, but it is a high stakes part of our job that we need to do, and it's a mandated part of our job to do. So just in terms of practical points, we have it, like I said, we have a mandatory responsibility. If you're a GP or a practitioner, you have a mandatory responsibility that if you have any suspicion that a child or a young person is being sexually abused or is abusing another child or young person, you are legally required to make a report to Child Protection. But there is no need for certainty. So you do not need definite proof. The action that you take in terms of mandatory reporting, it's required on what we call reasonable suspicion. So that's what you need. And if your clinical instincts raise a concern, that's enough to trigger a report. So, you know, if you do suspect child SA, you want to focus on the child's safety and well-being. You also want to document your concerns. And in terms of documenting your concerns, just record the observations you make, write down what the child has said, just using their own words. You want to note times and dates, the context of your concerns, but your role is not to be a detective and interrogate. And like I said, use the mandatory reporting guide. It will walk you through the decision-making process and reporting pathway. It's very helpful if the situation you're in is complex. And then you will make the report. And we will speak more to this towards the end of the session as well. Lauren, Robin, was there anything that you wanted to add to this?
No, that's fine. Thank you, Jen.
Okay. So look, we just spoke specifically to children and young people presenting and us recognizing and responding to child sexual abuse. This next segment will touch on historical child sexual abuse. So this is an adult who may have a history of historical child sexual abuse. So in terms of recognizing the signs, again, there are three kind of groups of red flags that we look for. Again, it is vulnerability, looking for vulnerability in their history, very similar to what we were looking for, with our children and young people. Instead of behavioral changes, we look more for the chronic history of chronic health issues. So, you know, adults who have experienced sexual assault in childhood or adolescence may later present with complex and persistent health concerns. So you want to look for, you want to kind of flag, is there any chronic pain syndrome? Are there long-standing mental health issues? Do they have frequent and unexplained health complaints? is their pattern of health service use, is it frequent? Is it very, very frequent? Do they have lots and lots of specialist referrals or mental health consults? And we all know patients like this. And, lastly, does your patient avoid, opportunistic screening? Do they avoid touching? Do they avoid recommended treatments? So, these avoidance behaviors can be really strong indicators of past trauma or abuse. And so these are things like, this is an obvious thing, but, screening, a cervical screening, or refusing breast exams, genital exams, being really uncomfortable with just physical examinations. If you have patients who are quite distressed, or even have patients who sometimes dissociate in the consult, is a sign of trauma and vulnerability. And if you have patients who frequently cancel appointments, or have frequent no-shows for specific types of care, they're things that you want to signs you want to look out for, in terms of, does this patient have trauma, and trauma which might be childhood sexual abuse. So again, in terms of questions, again, very similar concept to how we ask children and young people. So you can normalize your questions. For example, you can say, when I see presentations like this, I wonder if someone might have hurt you in the past, or, a lot of my patients who don't, who prefer not to do cervical screening tests. For those patients, a lot of them have had something happen to them in the past, something that's happened against their will. Is that something that's happened to you? So just questions, framing questions in that way rather than directly asking. And then if you want to ask a bit more childhood specific questions, you can ask general questions about their childhood, just like, what was life like as a child? Was their home a safe place? And you can narrow it down to, you ask them, did anything happen in childhood where you were hurt or that made you feel unsafe? And that's really up to you as to if that is something that is suitable, and if it is, and when to ask that. And once again, you need to, if you do get a disclosure, you want to validate ASAP, and it's exactly the same words as what we would use for children and young people. So for someone who discloses sexual abuse, so childhood sexual abuse, you want to address any immediate medical needs first. In terms of specific medical needs related to the sexual assault, they would be things like STI screening, pregnancy screening, emergency contraception. That is a very specific immediate medical need. And it's really only if the abuse has happened, within the past 7 days. It's someone who has gone through puberty. And you rarely need to examine that person unless they have pain related to a recent sexual assault. I'm not going to go too much into how you respond to a very recent sexual assault, unless we have time at the end and we have questions about that. And I guess, once you've addressed the immediate medical needs, then you want to continue to build that trust and make a follow-up appointment, and make sure you're making up follow-up appointments as well. And you also need to make sure you don't make promises that you can't keep. So we are all rescuers by just virtue of what we do for work. So we just need to make sure, that we are trustworthy, we're transparent. Don't make promises you can't keep. And like I said before, it's not your role to investigate allegations of sexual abuse. You really want to centre your questions around providing clinical care and management, because it may have forensic implications. So I have a slide here about the new child sexual assault navigator, who is Robin. So Robin, did you want to speak to this slide quickly?
Yes, thanks, Jen. I think this is a really key part of what we're bringing to you this evening, because as you can hear, if you're making these opportunities available by having a receptive and open practice, and you're prepared to ask someone the question, you're prepared to validate their experience and say, it's not your fault, and I can help, let's get you some help. That can feel really very nerve-wracking and overwhelming for you when you don't know where is that help. You're very busy with all the things that you do know how to do, how to recognize things, how to refer, how to get people to the right places. And this is where the navigator role comes in, building that connection between the primary care sector and the sector funded to then provide responses. It has become quite a fractured system with funding all over the place, so it isn't always straightforward to find the exact thing that might be going to help your patient. So one of the things is consultations and conversations about, this is what my patient said. That can be through phoning the number, so the number on the screen there, and that is in the CESPN website as well. Call the number, and there's two navigators, myself, child sexual assault and sexual violence navigator, and a domestic and family violence navigator. There's options on the number, and you can discuss the specific details with it, and anonymously, for your client's protection, or specifically to actually understand what could be available, what could be the pathway to that service. Sometimes families who are wanting to support children are also nervous about accessing the service system, and so some of that support is around providing the information. Children need that support of people around them, and that can be important to understand who is around them. And so the navigator can really help you and assist you to understand those parts, and then get towards the services that will provide support for the child and the young person. Thanks, Jen.
Thanks, Robin. So I have several more slides, but I will go through them very quickly, and I won't go through everything in the interest of time. The things that I will just quickly point out, in terms of referrals that you're going to consider, make sure that the referrals that you make are done with full consent of the patient. And also, if you are going to make a referral, what we call warm referrals are a good way to make that referral. So by warm referrals, that means personally assisting that patient in getting that appointment. So, and if you don't have time, if you have a trusted admin to do that, if you can get them to actually make the appointment rather than leaving it with the patient to do, that reduces barriers for that vulnerable person. And any documentation that you, any kind of referral content, just make sure it's trauma informed. If the patient consents to you including details about the assault, if you can put that in there so that the patient doesn't have to retell their story again and again to different people, that is also something practically that you can do, which is very helpful. In terms of recording, just try to make it objective. In terms of my work, I use alleged a lot, and it just adds a bit of neutrality to what's happening. And if you document certain quotes of what the patient, the child, the young person, the adult has said, that is also helpful. But just keep in mind that your notes are not it's not a police statement. So keep it clinical, like I said. Noting who's there is important. And then there's and confidentiality of the notes is important. So anything related to sexual assault is deemed sensitive, and it's not something that you want everyone in the practice to have access to reading. And so consider marking them as a confidential note with with a high level of privileged access. And just make sure that if there is something that is needed to be known, so in terms of referrals or management, that's another practitioner needs to know about in order to facilitate care in case you're not around. Make sure that is something that is kept as a separate public note that can be picked up on and carried forward by someone else. So that's just a practical thing for you to consider. And I think what I'll do is leave it there because a lot of the other practical information will come out in the panel discussion. Now, this slide is just a reminder that we have health pathways. Open that up if you're in the consult with a patient who has disclosed childhood sexual assault or sexual assault. It will give you really clear steps on how to contact Robin or who to call next or what kind of referrals you might be able to make. And it's a good way to collaborate with the patient as well there and then about different options too. So Nina, I think I will hand over to you. There you go.
Thank you very much, Jennifer, for that insightful presentation. Your expertise and passion have given us a lot to think about, and I think that sparked some probably very important reflections in the room. So we're going to shift gears now and dive a bit deeper into the conversation with our panel discussion with our wonderful speakers who bring very diverse perspective and experiences tonight. So I'm going to read out, and you can read along if you like, the case study. So Maya is a 35-year-old woman attending a general practice for the first time in several years. She has recently moved into the area and is seeking help for chronic fatigue, sleep disturbances, and persistent pelvic pain. She also mentions experiencing anxiety and difficulty trusting others. Her medical history includes depression, asthma, and a long-standing avoidance of cervical screening. And then we have the presentation, the patient coming to you. During the consultation, Maya appears withdrawn and hesitant. She avoids eye contact and seems uncomfortable when asked about her childhood and family background. She declines a physical examination, stating she doesn't like to be touched and prefers to manage her symptoms with over-the-counter medication. The GP notes that Maya has a history of missed appointments and limited engagement with previous healthcare providers. Maya's symptoms and behavior raise concern about possible unresolved trauma, but she does not disclose any specific incidents. So with that, I'll just throw our first question to you, Jen. So what signs in Maya's presentation might suggest a history of child sexual abuse?
So I guess this is where we think about the recognized principle. So you want to just glean the background information of what you've got. And from what I can see, there are a lot of factors indicating, or possible factors that might indicate vulnerability. She's female. She's middle-aged. I know that middle-aged women are the biggest group of people who are in domestic violence type relationships. I'm just brainstorming this. I don't know much about her. It says she's just moved into the area. Is she someone that has unstable housing? Is she someone that's moved place to place? So these are the kind of things that I'd be thinking about in terms of vulnerability. And then we talked about that second group of red flags, so chronic health issues. And yes, she has all the chronic health issues, almost all the chronic health issues that we discussed. So that chronic fatigue, the sleep disturbance, that persistent undifferentiated pelvic pain. She has multiple mental health, chronic mental health conditions. And we talked about, someone that has displayed avoidance behaviors or, difficulties engaging with care. So has missed out on that opportunistic screening time and time again, has not wanted to engage with more appropriate, or what we think is more appropriate medical treatment, wants to be what it seems to want to have easier access to the treatments that she thinks is more appropriate for herself. And then I guess just in terms of observations of her presentation, she's withdrawn. She's not wanting. She's just not engaging in a way I would normally expect from a patient. Declining the physical examination and wanting to be touched. All the signs are there that there is some kind of trauma. And then, it says that we have asked about her family history and maybe her childhood, and she doesn't want to go into that. So that makes me think, okay, it might be trauma related to childhood.
And what's happening for you in that moment as a GP potentially?
So it's very difficult because you think, okay, where do I even begin with this person? And if I was non-trauma informed, Dr. Jen, I would be and I was non-trauma informed Dr. Jen before. I'd be like, oh, this is going to take up all my time. I just want to get this. What does this person want? And I just want to get it over and done with. And I'll be looking at my watch. But reformed Dr. Jen, all these red flags for me, and just from my experience working at Headspace, all vulnerable young people working in the sexual assault space as well. People like this seem to have chaotic lives for a very good reason. It's usually due to trauma. I will come with it with curiosity now. Curiosity, and I want to see, okay, what is Maya, how does she want to start? What is her priority? And go from there.
Thank you, Jen. What's happening for Maya is a good, I guess, segue into Malika. Welcome tonight again. You are a lived expertise, or you have lived experience. And maybe you can tell us a little bit about how Maya might be feeling or responding in that consultation room in that moment. Um, and maybe like what cues might she give off, or that could indicate that something is happening for her.
Well, I imagine that a lot of survivors feel a lot of shame and a lot of feelings of worthlessness, and that, they don't want to be a bother. They don't want to disclose and share. They might feel overwhelmed that if they begin to disclose, that they may not be able um, to deal with that they will just be overwhelmed with all the feelings that come out. So they kind of want to keep it contained, not want to be a bother, don't want to talk about it, just be like, just get on with it and out as soon as possible. They might feel like they're not, as I said, the feelings of worthlessness and shame tend to be the biggest ones, that they're not worthy of help and support. And if she gives any clues that she wants help, it's going to need a feeling of safety and a feeling like the other person, that the doctor cares, and that she matters, that she has value, that she deserves to be seen and healed, and that it's okay for her to talk about her feelings and to uncork the hurt, I guess. That takes a lot of safety, a lot of feeling that, I know as a survivor, having somebody else be angry for me or to say that's not okay or whatever happened, this is a safe place. If you'd like to talk about it, that would be, this is a safe place for you. Although that's a kind of tricky term these days. What's a safe place and who's a safe person?
Thanks for that. I'm wondering with that, like, because you're saying like how might she be feeling? So what could the GP do that would make her feel like that safety that you were describing, or that it is a safe place? Like what could they, from Maya's perspective, do to help that or increase that?
I think talking in general terms rather than going straight into specifics will probably, just in general, the DP could say, in cases like this, we like to look at holistically your background, your history, that people who have these symptoms may have a history of domestic family violence or sexual abuse, and that it's important to address things that have happened in the past because they still will present in physical illnesses and disease in the present. So encouraging in a kind of going general before going into specifics will help, I think, make a survivor feel safer. That it's not like, you've been, targeting, are you a survivor? But more just talking broadly and generally first, and then coming in and sort of inviting the conversation to go, to come into the conversation to heal.
Thank you, Malika. Might just throw the same question back to Jen, to reformed Dr. Jen, because you were talking about like the previous Dr. Jen and the reformed Dr. Jen, which would apply trauma-informed care principles. So with that same thing, how can the GP apply trauma-informed care principles during the consultation?
Yep. So I guess I think the first thing, we talked about recognizing signs in the patient, that kind of thing. I think thing that we also need to recognize is so for patients like Maya who are withdrawn, they're anxious, they're avoidant of physical examinations, they have all these health conditions with no answers. It triggers heart sync, and we were talking about heart sync before, and we say heart sync patients. But if you are trauma informed, you don't say heart sync patients. You say it causes a heart sync reaction in yourself, because if you say heart sync patient, you've labeled the patient. That's not trauma informed. So we need to recognize it's natural for any practitioner, GP, physio, social worker, any practitioner. It is natural to feel frustrated and powerless, when you have patients with a lot of issues that are unsorted. But you really need to hold on to that feeling, and you need to recognize, okay, that's a cue that I need to pause. I need to bring that curiosity. I need to bring that compassion. I need to really reframe that, and recognize that those behaviors, the avoidant behaviors, they are protective responses to trauma. It's not that they're difficult people. And Malika really eloquently has told us that that they feel like they're not worthy, and so nothing gets addressed. So it's very natural for me just to instantly reframe. Okay, it's not about me getting impatient and angry. It's about the patient. Something's happening. Let's work together. So specifically for trauma-informed care, we throw that word a lot. It's everywhere. It's everywhere in the health space. Trauma-informed. What does that actually mean? And we know that there's the 5 principles. So the first one is safety, already touched upon by Malika. So safety, and that safety is I want to create that emotional safety. Easy. I'm not going to rush the consult. I'm going to let Maya set the pace. I'm going to have to just, take a bit of a backseat to that. I want to offer physical safety whenever possible. So, it said in the presentation she doesn't want her blood pressure taken. I can say, it would be good if we had a blood pressure reading. Would you be able to put the blood pressure cuff on yourself and tell me what the reading is? Very little things like that. It's creating that safety. And even just straight out acknowledging that she has all these conditions, and just saying, you know what, it's really challenging to look for care. And you must have had a lot of difficult experiences trying to get answers, and just acknowledging that straight out. And then I guess, so we talked about safety. Then the next thing is trustworthiness and being transparent. And so I want to, if I think it's appropriate, talk about confidentiality, or, in terms of being trustworthy, preempt what you're going to do, explain what it is you are hoping to do, and give them choice. If they want to do it, they can maybe just do a little bit of it, give feedback, and then maybe proceed. Just with little things, even doing it an abdominal examination, and you also, we talked about choice, giving Maya choice. So instead of me jumping straight to, oh, look, you haven't done your cervical screening, ask her, what is your top 3 things you want to get sorted? If you could sort anything out, what would it be? And then kind of work from there. And along with that, you're going to collaborate. And then you can actually say, and I say this to people, especially people with lots and lots of history, and I know is going to take a lot of consults to get through. I just say straight out, no one knows your story better than yourself. And I'm going to be really guided by what you have been through, what your experiences are, and, you know, let's work together and let's come up with a list of things and we'll tackle it from there. So really collaborating. Sounds cheesy, but it works. It works 100%. And then you're always going to be trying to empower Maya with every single interaction you have with her. You're going to be using that strengths-based knowledge, not just in speaking to her. When you're writing your notes, I'm not going to be saying, oh, she's declined, you know, she refuses cervical screening test. You know, Maya chooses not to have this done today. You know, and that way it's reframing. You're also reinforcing in your that to yourself as well.
Mm-hmm.
And it reduces burnout for myself.
Mm-hmm.
And it makes me look forward to working with her as my patient. Yes, that's my 2 cents.
Thank you. Thank you. I think that was very informative. I guess at the when you were talking about the trauma-informed care and the trauma-informed care principles, and like when, you know, there's someone in the room where there's something is going on, we don't always want to put our finger back into it, to not have that person have to relive that moment, retell their story, which is part of that trauma-informed care. And maybe at the risk here of like stretching that point a bit, but we've learned that the barriers are so that there is a lot of barrier in asking, and how do you ask? So Malika, maybe throwing this back to you for Maya, is there anything that you would want to add on, like, how can we ask about past experiences without causing harm or distress again and again?
I would say it's really important for the GPs, going back to the feelings, to let Maya know that all patients are worthy and there is no shame in expressing anything. I think
Mm-hmm.
that's really, really valuable for any doctor to let their patient know that, because it invites them in to be seen and to feel that they can relax and disclose. So um, I think that's probably one of the biggest things a GP can do, is just go, look, everybody is worthy. Nothing that happened in your past um, was your fault or that you should be ashamed of. So please, you know, and I think what Dr. Jen said as well, you know, like, what 3 things, what do you really want to address? What can I
Mm-hmm.
do to help you? Because it
Mm-hmm.
can feel, again, overwhelming to deal. A survivor might sort of just, you know, wait, and sort of pile all these things on top that need to be dealt with, and then just again feel overwhelmed, and then again feel ashamed that I've waited so long to deal with anything that's going on. So I think that that's a great way to help a patient, is to say, well, you know, what can I do? What is the number 1, 2, 3 things that I can do to help you?
Mm-hmm. Yeah, thank you. I guess the and like this is what I'm hearing from you, like building that trust. You know, it might not be that like this is the first, second, third, but like it's a like over a longer time, like people build trust and they check out like where's the safety, and then maybe there will be a referral one day if there is a disclosure. So I guess if that point is, or we're at that point where there is, you know, potential like a referral options or support that can be offered. Robin, like with going into, you know, if somebody's going to say, well, I would like to refer you, and that person has something to say about that, obviously, as we just learned, like that's the trauma-informed way of doing it. How would we manage that consent?
Mm. Yeah, it's a really good point to think about when you have somebody who is not really necessarily forthcoming or knowing. So when you've opened up that conversation and you've built some of that trust, and you're looking to what are your priorities, what are the things are happening for you, and as Malika said, you know, anything is okay to be thinking about or saying, then you don't know, as Jen was saying about somebody's situation, what is the highest thing for them. I actually don't know if I can feed my family tonight. You know, you could hear really things that you're thinking, oh, there's this past trauma and they need counselling and it's something, you know, therapeutic or whatever, but it could be any things like that. And then how let me see how I can help you with that, because that's okay too. They know they're at the GP. They know they're not at the emergency food bank, right?
Mm-hmm.
It's the honesty and the transparency of saying, let's see if we can help with something about that. And again, that's that trust. You heard me what my issue is, and you're wanting to respond with what can I do. And again, that support link of call us. You don't need to sit there and Google all the local support banks or whatever. You say, let's see what you can call the navigator. You can do those things if you know about your local area already and you know the service that could help that person. But if you don't, you can call, you can use the health pathways, you can find out. And again, that is helping to respond. And then you are alongside that person. Can we, would you like us to make that call together? Is it something that you're happy to do on your own? That is all about considering consent and considering the person being alongside you, being alongside them in their journey and their responses. Where they probably the only other thing to say is where they're not wanting support, where they're saying no, I'm not ready, I don't want support. Sometimes it's good to have a resource there that gives some options, and we can assist with that type of thing as well, where you can say, would you like to take this with you? If you think about some things that have come up for you and you do think you'd like to access some support, these numbers here are numbers you could call if you were thinking about that later. Would you like to take that? Again, you're interacting there can be a no, there can be a yes.
Mm-hmm. Thank you. And thank you for drawing out that collaborative moment there to really work with the person. I guess as Jen said, there's a lot of power and control. Like there's a huge power and control aspect in that, in those experiences as well. So I just wonder, Malika, would you like to add anything for like how consent should be managed? Or could be managed in for Maya?
I guess it's about letting Maya lead, and you could offer her resources, or even if she wasn't ready for that, I was suggesting that maybe you could leave resources on the table and say, look, I'm just going to step out for a moment. Feel free to take any of the resources on the table while I'm gone, so that there's no direct pressure to watch her. Just give her a moment of pause, but also to help her to understand that there's many ways to heal her physical symptoms, and that it's not necessarily about talking to others. It could be about movement, yoga, art therapy, writing. So just letting her feel that she has power over her own healing journey, and that there's no pressure. Because I think a lot of victims, survivors, can feel, again, just that, oh, I'm doing the wrong thing, just feeling just so overwhelmed and overthinking things. And so letting there be some space can also be helpful.
Yeah. Thanks, Malika. I note that we're almost at the end of the session, but just one thing, and this was briefly touched in the presentation, but Robin, you are the Child Sexual Abuse and Sexual Violence Navigator for CESPAN in this project, and GPs can call you for consultations, as you said, or you can make referrals together. There's a whole array of things that you can do. But is there anything that you would like to add from tonight in terms of documentation? Because it's always a bit of a sticky point. And is there anything that you would like to add for tonight on how a GP could document a consultation and plan for follow-up care?
Yes, I think the points raised earlier were really about being specific in terms of writing down what someone says that could prompt your knowledge for when they come back in as well, so that you remember, you have a prompt that gives you a sense of, oh, that's right, this was my, this is what we talked about before, this is what, and sometimes a note in your documentation about what was not taken up, what was there was interest in, but what was not taken up as well, could prompt you. So you could consider, oh, I remember speaking about some of the things that might be available, and I wondered how you felt about that this time. And it's not assuming that there's been no thought, but it's not assuming there's been a lot of thought either. You're just opening it up, and it just prompts you as well that some of those things were discussed, and an idea of what you can bring forward. That's another helpful thing to document, and doesn't compromise the record, for the patient. That again is about trauma informed response and building that trust with somebody.
Thank you, Robin. Jen, is there anything you wanted to add? I saw you nod.
Um, Not really. I think they're the most salient points in terms of documentation. Don't overthink it too much. Just keep it objective, keep it practical, and just keep in mind, yes, possibly your notes might be used in court. It might be a very far possibility, but keep it at the back of your mind and just make sure the language you use is appropriate. If the patient was ever going to read that in whatever circumstance, you want to be seen as neutral, and use that person-centered language.
A good tip. If the patient was ever to read that, what would they think?
Mm-hmm.
We're out of time, unfortunately. If there are any further questions, they can be emailed, and we will look to respond to them if there's anything that somebody would like to know. We're just putting up the numbers for help if anybody would like to reach out. We are also available. I just want to say a special thank you to you all. Thank you for joining us tonight. Thank you for tonight's speakers. Thank you all for attending. And yes, this was very informative. I've really thank everyone for being here, and please complete the online survey that will pop up on your web browser, as well as a post-training survey that will be emailed to you following the session. So thank you very much, everyone. Have a good evening. Go and do something good for yourself, some self-care. It's been a heavy topic, but like I said, well, thank you all for attending tonight, and we look forward to seeing you soon again. Thank you. Bye-bye.